Well, today we're going to talk a little bit about burns. Burns is one of those subjects that when you talk to people about them, they either go, or they go, that's probably one of the worst ways to die is by burning. And so it's really kind of an interesting topic. And so we're going to look at the different things that cause it. We're also going to look at different ways that we can help take care of patients who have burns. So basically, here you can see burns are basically an injury caused because energy and biological matter is interacting. Your six major causes are scalds, contact burns, fire, chemical radiation, and electrical. And according to the American Burn Association, approximately 2 million burn victims in the U.S. each year require medical care. Approximately 70,000 are going to be hospitalized, and about 12,000 are going to die. It's probably around the third cause of death in the U.S., okay? And it's also the highest burn injury of all industrialized countries, unfortunately. About half of all these fires that we have could be prevented. The risks are highest in our children, 18 to 35-year-old group, and then the people of age, okay? More serious burns and deaths occur in males, about 67%, and it costs about $4.8 billion to take care of burn victims. I'm sure that cost has probably gone up a little bit by now. So what happens with the burns? We see protein denaturization, womb edema, loss of intravascular fluid volume, increased vascular permeability, cell membrane breach. You're losing a lot of fluid at this particular point. Remember, your skin is your first line defense against infections. Your body temperature control, it does help maintain the fluid that you need. Once you've lost this protection, unfortunately, now you can have a negative impact on the entire body as a result of it. Also remember with burns that it helps synthesizes vitamin D. It is also part of your contact with the world as well as part of your identity, and people recognize you with your cosmetic appearance and things like that. This is just an overall picture that shows you what can happen when you have burns, and it starts at the brain and it works all the way down into the feet at this particular point. And you can see with the lungs, edema, acute respiratory distress syndrome, bronchospasm, pneumonia. As far as the skin, there's your fluid loss, edema, infection, and other things that go with it. And this is just a picture to show you what can happen with a burn. This worker was actually shocked by his tool. You can see the entrance and wound and the thermal burns from it. When you look, let me grab my pointer here. There's the pen. There's injury at this point, okay? And then there's also injury over here. So you can see these two areas at that point. This is the same hand later. As you can see, there's massive subcutaneous tissue damage at that particular point. There was swelling that peaked at somewhere around 24 to 72 hours. And basically what they had to do, because of all the damaged nerves and the blood vessels, is they had to do what they call an escharotomy. They had to cut it open at that point. And you can see, look how minor that is. Now look at the damage that you have over here, and then you can see the rest of the damage on the hand at this particular point. So for the most part, burns lead to decreased cardiac output, a lack of a volume for resuscitation. You have a decreased hematocrit because you've lost your plasma and you've lost your fluid. It's a relative increase. And then you have a significant metabolic acidosis in burns also. The American Burn Association will tell you 44% of all admission to burn centers result from fire or flames. 33% of all burn center admissions result from scalding injuries. And this is fluid, this is wet. And this is really something that we have to be aware of because the moisture can carry the burn particles deeper into the lungs at that particular point. Direct contact with a hot source accounts for about 9% of your burn center emissions. Electrical burns account for about 4% of those emissions. Chemicals account for 3%. And then the remaining 7% are caused by other miscellaneous sources. And scalding is the most common burn injury in children under 4 years old. And there's something like 200,000 of these per year. And then an estimated 50% are from spilled food and water, basically pulling things from the stove. Irons are another one, we see those, stoves and water heaters. And then basically each year, roughly 250,000 children under age 17 require medical attention for burn injuries. So here's thermal burns. You have a few other things on here. I thought this was kind of interesting. Thermal burns result from an external heat source. It raises the skin temperature and it causes deeper problems at this particular point in protein coagulation or charring. About 5% of your hospital patients will die from these injuries. Most of them are from flame, and most common cause of the flame injuries are alcohol. That's about 26%. And these are the most common causes of burns and scalds. You can see the hot water, heaters, the oven, frying pans. How many of you guys have ever tried to take something out of the oven and not thinking about it, you use the hand that you didn't have the glove on or whatever to be able to protect your hand? You know, things we don't think about. Curling irons, I know for you guys, you probably don't have to worry too much about that, but a lot of times you're doing curling irons, and I've seen people come to school or come to work and they've had burns because of the iron, either on their ear or on their face at that particular point. And then drinks, don't forget the famous McDonald's problem with their hot drinks where the lady sued, and I think she won about $1 million, if not a little bit more at that point. So there's different things that can cause thermal injuries. Frostbite is another one. We can see this. It can also be very severe. It can go to deeper levels at this point, and you can see that we can look at it and see how deep are those levels. Sometimes you do not lose your fingers or your hands, but you also have problems with them later on as a result of it every time they get cold. And then 44% of all emissions to the burn center from fire or flame burns. Some of these actually also come from the sun. So here you see a picture probably of a young lady who pulled some water down from the stove or else had something spilled upon her. And then you can also see the snake at this particular point. If you want to see some sad injuries, if you're a pet owner, you can type in thermal injuries to dogs, and they'll show you all the injuries that dogs get from being out in the heat. You guys probably remember too, about 5 years ago, some man took his dog up Reddington Pass. It was a really hot day, greater than 100 degrees outside. He had to call 911 to get the dog taken down because the dog's pads were all burned. And I think he was fined for that. I don't know if he lost the dog or not. I can't remember at that particular point. So just be careful. Thermal injuries are really bad, not only for people, but for dogs and animals. Chemical burns, these are your acids, alkalis, different things along that line. Not many of them, about 9% of burns, but enough to make a difference if you want to think about it. Basically with these, one of the things that you need to know is what the chemical is before you start doing anything with this person. So if there's an explosion somewhere and you go in and you see the signs and it shows you the chemicals and everything, you need to know what are they and how they're distributed. Are they in the air, or whatever. Make sure you protect yourself. In some cases, if it's just like a powder, you can go ahead and brush it off, but be careful with that. Some cases they'll use water. If you're going to use water, don't spray it at a high spray. You use a very low spray to rinse it off. And this happens to be a sulfuric acid burn that you can see here. Radiation burns, sunburn, I imagine most everybody has had a sunburn one time or other in their life. And this is actually because we stay out there and we don't think very much about it. The other places you can get some radiation burns are if you're going through chemotherapy and radiation therapy. You can also end up with burns. Remember, you can put a person in the hyperbaric chamber to help rebuild that tissue and rebuild the vascular system after they've gone through radiation therapy. Another one too is people who are in tanning booths. They'll end up with radiation burns also. And you can see this person has a pretty nasty one. Electrical burns, these are about 4% of your burn center emissions. They're either classified as high voltage, greater than 1,000 volts of energy, or low voltage, less than 1,000 volts of energy. Basically, what happens is the skin transforms the electrical energy into heat. This produces burns around the area, and if you're looking at this picture here, you can see at this particular point, there's the burn. If you notice the location of it at this point, look how close to the spinal cord he is at that particular point. So you definitely have to be careful with these. And these are the tables that I found. One is the physiologic effects associated with various electrical current strengths, and it shows you, for example, 3 to 5 milliamps is a let-go current for a child. A let-go current means that you're probably going to be tossed away from what it is, or if it's low enough that you can actually drop it at that point. For a female, it's about 6 to 8. For a male, 7 to 9. Okay, and then tetany occurs at about 10 to 20. And tetany, you're not going to be letting go. You're really frozen to it at that particular point. Somewhere around 20 to 50, there's your respiratory arrest. Secondary to thoracic muscle tetany, and 50 to 100 gives you VFib at that particular point. And then it just compares on the next table 3, the comparison of high voltage and low voltage electrical injuries. And there you can see too the summary and multi-system presentations, the different things that can happen: cardiac arrhythmias, cardiac arrest, respiratory arrest due to muscle tetany or central nervous causes, vascular aneurysm formation or tissue ischemia is another one. Lots of other causes that you see. And this is kind of interesting. This is a kissing burn. And a kissing burn basically is there's an electric arc generated between two skin surfaces that face each other and are sandwiching a joint, okay? And most commonly it's in the knee or the elbow. And basically what happens is the arc crosses the flexor crease and burns the two kissing skin surfaces, causing a lot of tissue destruction at that particular point in time. Okay. And this is what you're looking at this particular point. You can see all the damage. Look at all that. Electricity will follow the path of least resistance, and it will get the nerves, the blood vessels, and muscles have the highest damage. Nerves have the least resistance and bones the most, okay? And what you're looking at here is involuntary muscle contraction. What happened with this person is the worker fell and grabbed a power line to catch himself. The resulting electric shock mummified his first 2 fingers, and they had to be removed. And the acute angle of the wrist was caused by burning of the tendons, which contracted at that particular point. And what you can do with these sometimes is sometimes you can get new tissue. You can sometimes put saline in these areas and be able to sometimes straighten that out at that particular point. But you can see all the damage that was done. So what all is involved with electrical effects: the type of current, the amount of current, the pathway of the current, how did it enter into the body. We can see the entrance wounds, we can see the exit wounds. Problem is sometimes we can't really tell where it went, and so we can sometimes run into problems with that. We also look as to how long you were in contact with the object. Where did you this occurred. In this case, as you can see, it occurred in the hand and the arm, the body resistance, which is your ohms, and then the voltage that was involved. And this is your exit wound. And if you look at this, it doesn't look terribly bad, does it? No, it does. We have a higher mortality due to damage that you can't see. As I told you, we don't know sometimes where it's going at that particular point. With this one, this foot suffered massive internal injuries, weren't readily visible, and had to be amputated a few days later. So the types of current we see are direct current, alternating current, and then we're going to talk about lightning, and that's why you see that bolt over there. Direct current is basically safer than alternating current. It's intermittent pulsating, things along that line. You just have that in Europe and a lot of other countries. In the US, we mainly use alternating current, and this is more dangerous than we see with DC. So this is a lightning strike. Remember, here in Arizona, we have some really beautiful lightning. This is a slide that my pointer got a little bit away from me on. I apologize for that. But at the higher amperage and voltage, that's where the greater damage occurs. And you can see with the higher ones, we have deeper burns. With the lower ones, you're pretty well frozen to the circuit. You can't let it go. And then the let go current, this is going to allow your arm to contract and release from the source. Problem with the let go current is sometimes you're tossed with this. So you can be tossed into a tree, a building, wherever it happens to be at that particular point. Okay, so lightning for the most part. Did you guys know that there's 8 million lightning strikes to the earth every day? Fortunately, we don't see too many of them, but they are out there. How can you get injured from a lightning strike? It can be a direct strike. It can hit you in the head, especially if you have metal in your body or anything like that. The head is the reason for the highest mortality. It can enter your eyes, your ears, your mouth, whatever at that particular point. A flash discharge, for the most part, is when another object is struck. You can think about trees or picnics. You're sitting there, it hits a tree, and then it's going to splash over, and unfortunately, you're going to be killed at that particular point. If you remember, many years ago in Tucson, there were a bunch of homeless folks. It started to lightning outside, and what they did is they ran underneath the tree. There was a discharge that struck the tree, and all 8 of them were killed as a result of the flash discharge. Contact is touching it, ground current, the open air open. You're a good source. You're right there, and it's really good. Take care of it. The ground is a good insulator, and the person, unfortunately, is a good conductor at that particular point. You get blunt or blast trauma from being hit by something or being sent to something at that particular point. Streamers are interesting because sometimes what happens is the lightning is hit, but then it starts to come back up, and when it comes back up, it goes across and it finds you. So from the year 2008 to 2017, there's only like an average of 27 deaths per year. Florida is the #1 area where most people are killed. Texas is probably #2. And then there's still other areas that we also see it at that particular point. So here's one that's a double one. This one you can see the lightning, plus you can also see the tornado at that particular point. These are Lichtenberg figures. It's named after the person who came up with these or named them. You also have something called Cara uniparalysis too that can happen when you do get hit by lightning. The Lichtenberg figures are a fern-like shape. They show up as different types of material. That tells if you went in and said, I got hit by lightning, they see these, they know in fact that you have had those. And these can actually last for like hours or months, but eventually they'll go away at that particular point. If you want to, you can actually make one of these by yourself. What you need to do is go to a laboratory, place a needle onto a plate of glass, and then sending electric current through the needle into the glass, okay? And when you look at it, the results will show you these figures at that particular point. Okay. And what do they think these are called? Um, Basically, they're called lightning flowers as a result of what they have. And paralysis basically is weakening of the muscles and the nerves, and it mainly occurs in the lower limbs in your legs and things like that. And this will last for about 24 hours, sometimes a little bit longer too. So current pathway, basically, pathway through the body is going to tell you how the injury is, okay? If it's traveling from the arm to arm or between the arm and the foot, most of the time it's going to go through the heart. Cataracts, as you can see, are one of the things you can have. They develop in 6% of patients with high voltage. Some of them may come up immediately. Other ones wait a while before they do develop at that particular point. Another one, you can have hearing loss, tinnitus or vertigo at that particular point. If you get hit, that's another way we know that you did. The mechanism is the rupture of the eardrum by acoustic trauma or the flow of electric current through the cochlea and the hemorrhaging at that point. And then you can also have an injury to the eighth cranial nerve, and that's where your chronic tinnitus and imbalance problems will come. And then the other thing you can end up with is infection complications, okay? And other things that you can see are neuropsychological issues such as depression, cognitive dysfunction, attention problems, anxiety, chronic pain. And you can end up with complex regional pain syndrome also. And that's really kind of hard to diagnose because people don't recognize it a lot of times, and at that particular point. Probably some of the worst things that you see and hear are seizures, and intraventricular hemorrhaging, respiratory arrest, cardiac arrest. You'll see with BFib and then asystole also. Duration of flow directly proportional to the extent of the injury too. The longer you're in contact, the more breakdown occurs. And remember, you've got heat that's going through your body, so it has a tendency to damage whatever it goes by or through at that particular point. You remember when we talked about CPR, you have to overcome transthoracic impedance, which is measured in ohms. If you can look at this slide, you can see you have a lot of ohms. It just depends on the condition of your skin. However, what you need to remember is once you add water to it, and this is the reason why we use the gel when we're trying to shock folks, is that we can get rid of these ohms, decrease them quite a bit. And many years ago, there was a police officer directing traffic in a rainstorm. The lights were out. He was wearing leather shoes. He was standing in the puddle of water. One of the electric wires came loose and fell into the puddle, and he was electrocuted at that particular point in time. So you always have to be careful and watch out for it. I know you probably have seen movies where someone's in there taking a shower or a bath, and they really torqued off their significant other, who then threw the TV in the shower or the bath, and the person died as a result of it. So, moral of the story is always be nice to before you take a shower. So there it is, your skin. You guys remember this from anatomy and physiology. It does regulate your body temperature. It protects against bacterial infection, prevents fluid loss, and it is your sensation in contact with the environment. So the outer layer remembers the epidermis. You have the stratified epithelium. It provides the barrier protects you from microorganisms, and that's where you're going to retain your water and electrolytes. And then you have the different terminal basal cells and the different stratums. Underneath the epidermis is the dermis. Okay, remember this controls or contains your special glands, appendages, your blood vessels, your lymphatic vessels, sweat glands, all of those different things. Underneath the dermis is the subcutaneous or hypodermis. layer. This is your fatty tissue. It does have some of your skin appendages, glands, and hair follicles, okay? It also is very important for regulation temperature of the skin and the body, and, it helps to keep you well. So when we talk about burns for the most things, if you read most of the literature, it's going to talk about first, second, third degree burns. Sometimes people talk about fourth degree burns. Sometimes they talk about fourth, fifth, and sixth degree burns. We're going to talk about what burn centers use here shortly. But if you look, this first burns, which are also called superficial, these are red, pink in color, they blanch, they're painful, there's no blisters. It takes about up to 10 days for them to start to heal at that particular point. Your second degree, and this is what the burn centers use, are superficial, partial, and deep partial. There's two of them in the dermis. These are deep red in color. They blanch also, or they have slow blanching. Very painful because of the nerve endings, okay? And you can have blisters or you may not have blisters at this particular point. They're very moist in appearance and takes about 21 days for these to resolve. The third or your full thickness burns, and these are white, black, brown, gray, whatever. There's no blanching. There's no pain associated with it because you've already gone through the nerve endings. No blisters. They're very dry or leathery in appearance at that particular point. So there you see they classified them in all these different things, and this is what the previous slide showed you. This one, as you can see, this is a mixture of first and second degree burns, or superficial and partial burns at this particular point. This person should have put this in ice water to reduce the extent of the burn, but you can see the blisters that go with it. Third degree or full thickness burns. These are the entire thickness of the epidermis and dermis. The dermis really doesn't regenerate. Definitely the subcutaneous layer has no regeneration at all. And this just shows you again the different classifications that they are. A little bit different time with some of the times, but not a big deal. So burn centers basically use superficial partial thickness burns. These are the outermost part of the dermis. They use deep partial thickness burns. These go through the dermis at that particular point, and then full thickness burns. Things to watch for: burns greater than 40% of your body surface area, greater than 60 years of age, and presence of inhalation injuries are all risk factors for death. And for people over 60, basically, if you have more than 40%, well, if you're over 60, that's like a 0.3% chance of having it, dying from it. If you add that 40% BSA, now you're up to 3%. Once you throw inhalation injuries in there, you're up to about 75%, unfortunately. So the older you are and the worse the burns, the more likely you're not going to survive them. Okay. In burn centers, as you guys know, there's not a burn center here in Tucson. The closest one is up in Phoenix. We stabilize these patients and then send them up there. The requirements for burn centers, they have to do everything. They have to rehab, they have to train people, they have to do all kind of research for them. Most of them are found in hospitals with greater than 500 beds in their university centers. At that particular point, your director has to be a board-certified general plastic surgeon, and they have to have an additional year of training. You have physical therapists and licensed dietitians that go with it too. So some things that you need to do is you have to monitor these patients really closely, strictly insulin levels, because if it's too low, you're going to have infections and complications and mortality rates. Anabolic adrenogenic steroids. These give you your hypermetabolic state where you have catabolism. You have to feed proteins. You have to maintain nitrogen. And we'll talk a little bit about that in advanced patient assessment to help these patients heal. And then beta blockers are something else that we need to do to reverse your muscle catabolism. So what do we want to feed you when you have wound issues or burns? Amino acids, albumin is one that we need, carbohydrates, fats, minerals, copper, iron, zinc, and their different vitamins. And the thing about feeding these patients is you have to feed them early on because they are in this hypermetabolic state. So how do you get to a burn unit? Basically, greater than 10% of your body surface area in a child, greater than 15 for adults, inhalation injuries, airway burns, electrical burns, chemical burns, special areas, your hands, your feet, your eyes, your groin, are very special areas, and they will get you to the burn center. Other indications in these cases, pre-existing medical disorders that are going to cause problems with you, people who also have trauma, and the greatest risk of morbidity or mortality. Children need to be looked after, and then patients requiring special social, emotional, rehabilitative interventions at that particular point. So you have to contact the burn centers and decide, do these patients need to go and will they be accepted? So remember to find the burned areas that use the rules of 9, okay? And basically, as you can see here, any burns greater than 20 to 25% of your total body surface area are going to require fluid resuscitation. We'll talk a little bit about the Parkland formula, how do they basically come up with this. And then, as you can see, burns greater than 30 to 40% may be fatal if you don't treat them. And this just tells you how to go ahead and figure out what their percentage of burn area is. For children, they use the Lund-Browder scale, okay, and it tells you the same thing. So how do we diagnose and differentiate these between major, moderate, and minor? Major, full thickness greater than 10%, or partial thickness greater than 10% involving your hands, your feet, whatever. Minor, partial thickness is less than 10, or the full thickness less than 2%, and in moderate is anything in between. So Parkland formula, basically, you take the fluid requirement, what is the area that's burned, times the weight in kilograms. They use somewhere between 2 to 4 mLs of fluid that we're going to use at that particular point. And basically, once you come up with it, half of it is given in the first 8 hours, and then the second half is 16 hours, over the next 16 hours. What else I want to tell you? That's about it. So fluid resuscitation, some interesting things. They've done some studies trying to decide if they want to use colloids or crystalloids, and they said basically crystalloids are really, really good. Colloids are sometimes too expensive. Not only that, some of the colloids are involved with more increasing morbidity and mortality. And so as a result of that, you can justify using the crystalloids, but not the colloids or the starch, things like that. So any burns greater than 20-30% have both local and systemic effects. We see coagulation of cellular proteins, production of complement. Complement is something that's good, except complement are like proteins that come and help you heal when you have an injury. The problem is if you produce too much of complement, now it becomes a mediator of inflammation and other non-healing aspects. If you think about it, it's almost like having the neutrophils when they come into an area and they're there to help heal, except that they're also there to activate inflammatory mediators to come and help heal. So sometimes you run into problems with that. Histamine is another one that we have to watch out for. And then the O2 free radicals. Remember, O2 free radicals are pretty bad with the neurological system and cause different issues with us. And there it is with the complement and histamine, increased vascular permeability, the O2 free radicals, tissue injury and edema. See a lot of red blood cell destruction and hemolysis. And then you alternate the DNA at that particular point for total cell destruction. So what do we do to find out what's going on with these folks? You have to do your initial evaluation. It's going to be very similar when we talk about trauma patients. What we're looking for, what are the injuries that this person has? In addition, we're going to look for mucosal edema, a compromised airway, stridor and hoarseness. If this patient has stridor and hoarseness, coughing up black soot and things like that, there's probably a good chance they have an airway injury, and you may want to think about intubating them at that particular point in time. You need vascular access. Hopefully you can do it where there's not burns, skins, but sometimes you do have to do that. You're looking for carbon monoxide. You're looking for ABG, the acid-base balance. A lot of the burns are confined to the upper airway. It takes steam and smoke to get it to the lower airways, okay? And so we have to watch what's going on in that upper airway. The facial burn, classic predictor, blistering, vascular congestion, all of those things can be seen. The other things we want are lab baselines. We want chest x-rays, replacements or absence of chest trauma. We don't normally see inhalation injuries early. It takes a little while for them to finally show up. They may show some pulmonary edema, atelectasis, or some infiltrates at that point, but we may not see everything that we're going to see as time goes by. So how do we diagnose inhalation burns? Dyspnea, retractions, wheezing, a sore throat, nasal flaring. There's your black sputum, confused behavior, cyanosis or cherry red coloring. Do not rely on cherry red coloring to tell you the level of carbon monoxide poisoning, okay? It can sometimes be covered with something else that's going on. Singed nasal hairs, facial burns, different things like that. Look for hypoxemia, look for metabolic acidosis. Metabolic acidosis may tell us that you have cyanide poisoning or hydrogen sulfide intoxication. So what produces inhalation burns? Steam. Steam holds more heat than dry air, much more dangerous. It can reach the lower airways. Hot, dry air, fortunately, doesn't reach the lower airways, but it causes swelling and laryngeal spasm. Smoke has a lot of stuff in it. It's got the cyanide, it's got the hydrogen sulfide, it's got the carbon monoxide, it's got soot, it's got all of that stuff in it. And that's reaches the lower airways at that particular point. So what do we see with this? Pulmonary edema, pneumonitis, and then your carbon monoxide levels greater than 60% starts a real bad morbidity and possibly potential mortality. So what do we see with this? There's 3 stages that we watch: early, intermediate, and late. We're looking for things from starting with the acute upper airway, bronchospasms, small airway occlusions, pulmonary infections, all leading to respiratory failure. And there you can see the different things that you can see in those different areas. So early on, the things that we're going to look for: hematocrit, electrolytes, your BUN, which is your blood urea nitrogen level, that's from your protein breakdown, your analysis, your ABG, your CO, carbon monoxide, glucose levels. We're doing ECGs also. We can also do a bronchoscopy to take a look and see, what does the airway look like? And, are we looking at collapse? Sometimes you can also use the bronch to remove debris and cast, and looking for infectious events, okay? So the first 24 hours, 0 to 24 hours post-inhalation. We're going to see that inflamed tracheobronchial tree, airway obstruction, bronchospasm. You're going to have decreased mucosal ciliary transport, non-cardiogenic pulmonary edema, and you do need to be intubated at that particular point in time. And things we're going to have to watch for suctioning, and you may have to have chest physiotherapy to remove this, help remove the tissue and the sloughing off that we will see. And this is a picture of a child, a young child, and you can see the swelling and things that go with that. Intermediate stage is about 2 to 5 days post-inhalation. The upper airway is going to start to heal. The problem is the lower airway is actually getting worse. We have more mucus being produced, decreased ciliary transport, mucosa becomes necrotic and sloughs off. You have mucus plugging, atelectasis, colonization, O2 toxicity. Even though you have a lot of problems with oxygen crossing the alveolar capillary membrane, you still have a lot of oxygen in the thoracic cavity, and that's going to cause some of your injuries. You also can end up with some ARDS. We still have to watch your fluids. We do have to give you fluids, but we also have to watch that, and we can measure that with your urine output. 3 to 5 days for the most part. We're going to have sloughing off of necrotic tissue, more atelectasis. Another bronchoscopy probably has to be done. Pulmonary hygiene is really, really important. Pneumonia, tracheobronchitis is going to happen at these particular points. We're not going to use a lot of steroids during these treatments because unfortunately steroids are going to also cause inflammation. If we have to, we will, but we're trying to avoid that as much as we can. Late stage, for the most part, these are 5 days or more. We're looking at the wounds on the body. What normally causes death is sepsis and multi-organ system failure. Your multi-organ system failure basically comes from the lack of oxygen to your different organs, and this is because the oxygen is being withheld. It can't cross the alveolar capillary membrane at that particular point. Pulmonary emboli you can have in about 2 weeks, and we'll see some restrictive and obstructive disorders. Some folks will tell you, and I also agree with this, that these restrictive and obstructive disorders for the most part don't last once you heal. You may have a few issues with them, but not long term for the most part. Okay. Some of the things we also see, tracheal stenosis, bronchiectasis, and BOOP are very rare occurrences, but they can show up. So what do we do with these patients? We have to do what's called an escharotomy. And basically what happens is that as skin heals, it tightens. And if it's on the chest, what it's going to do is compress everything in the chest, the heart, the lungs, and everything. And you have to be able to release the skin in order to do this. And so what happens, and I'm not sure if you can see this or not. Let me get my pen. It didn't work too well. But anyways, you can see these areas with blue. This is where the escharotomies are done, okay? And you can see the ones on the chest up here. You can see around here at this particular point. And I'm going to mention at this point with blisters, if you have blisters over joints, what they'll normally do is try to puncture it and allow it to drain out so that they can start working with them and get these joints to move. Most of people will tell you now, don't break the blisters and pull the skin off. Some people will say, yeah, maybe you can do that, but sometimes they'll take a needle and just puncture it and then keep an eye on it, leave the tissue covering it to prevent infections. Down here you can see too, around the legs and the ankles, that you'll have those escharotomies that are being done. And what you do is you cut into the skin, and the skin has to bleed, and when you see bleeding, you know that you've gotten deep enough at that point. Another thing are debridement. Debridement can be very, very painful. The primary method that they do is kind of interesting. It's called BEAMS, B-E-A-M-S, and it's mnemonic. B is the biological debridement. And this is kind of interesting. They found out using magnets are really, really, really good. There's 2 types of maggots that you can use. One is confined and one is contained. And the ones that are confined are called free range maggots, and the other ones are just called contained or bagged maggots. And the free range maggots actually have like a 14-day healing. The contained ones or bagged ones, it's like 28 days for healing. And if you don't use them, it's a humongous amount of time, like 2 months or so, before you see any healing at that particular point in time. So, sometimes the problem is if you tell somebody, oh, your loved one has some maggots on them, people have a tendency to go, oh, but they're really, really good. The next thing you can do is enzymatic debridement, okay? And you can use topical agents that chemically liquefy the necrotic tissue with enzymes, and they basically dissolve and engulf the tissue with the wound matrix. And you can use some antimicrobial agents with this also, okay? The A is autolytic debridement. It's very slow. It's most commonly used with long-term care. There's no pain with this one. It uses the body's own enzyme and moisture beneath a dressing to go ahead and liquefy this tissue for you. And normally they use hydrocolloids, hydrogels, and transparent films to be able to do this, okay? And then the last is mechanical debridement, and this is by irrigation, hydrotherapy, wet to dry dressings, and a braided technique. And this is usually very painful, okay? And so, a lot of times if they're doing this, they don't knock these patients out, but they'll try to take some of the edge off, but that's basically what it is. And this is a person who was burned, and if you look, you can see the escharotomy on the chest at that particular point. And this is the same child that you looked at before. You can see the escharotomy on this child too, because they had a burn on it. Now, one of the things that they talk about with children, and you can see with adults too, is this an accident or is this some type of abuse? And the way you can sometimes tell it's abuse is the burns start and stop. They have a very clear line of demarcation. It's like somebody put their arm or their hand in water and then pulled it back out. Another thing they see with children sometimes is if you put them in hot water, they'll drag their legs up and try to protect the back of their knees. And sometimes you can tell that this was abuse that happened at that particular point. And you can see on the hands, they also had to do the escharotomy. And you can see where they did those with the fingers. And then they also had to do fasciotomy because of the underlying damage and the tightening of the skin at that particular point. So how do we care for these patients? Some of them have to be intubated, some are non-intubated. Non-intubated, always monitor the respiratory status. We're going to give you that 100% oxygen to try to get rid of the carbon monoxide poisoning. If it's high enough, you can go to the hyperbaric chamber. You're going to have to watch for airway clearance. There's a lot of wheezing at that particular point. So bronchodilators and mucolytics are some. An epi for the wheezing. Aerosolized heparin is another one. Chest physiotherapy, anti-suctioning, and get these guys up and move. And you need to make sure that the family or the caregivers are aware of what's going on with this patient so that they can help participate with them too. Intubated patients, you're going to do the same thing. If we put you on the vent, we're going to use some pressure-limited ventilation to control the amount of pressure that's moving the airway. Permissive hypercapnia is an interesting one. In order to allow better gas exchange, we're going to allow the CO2 to increase. If you remember, as you become hypercapnic, you get vasodilation. And as a result of that vasodilation, now we're able to get better gas exchange. Thing is, you just have to set your goal. How low do you want the pH to get? In some cases, people go as low as a pH of 7.2. Just have to watch it because that patient's really acidotic. Inhaled nitric oxide, but be careful with that also. Remember, you can get methemoglobin with it. ECMO is something else that we've used. There's your low tidal volumes, and sometimes you do have to have tracheostomies to go with it too.